All right, everybody. Thank you for joining. I want to welcome you all to the very first inaugural Mid-Atlantic Allscripts Regional User Group meeting. We're really excited to finally get this off the ground. It's something we've kind of had in the back of our heads for a lot of years. We had a client recently that specifically asked for something like this, so it kind of put a little bit of impetus behind it. So we've finally gotten this going. I'm just gonna cover a few things here, just to give you kind of an idea what we'll be talking about today. We're here for about 2 hours, give or take a little bit of time, probably on the short end of that. Want to do a few introductions, talk about who's here today, what we're going to be doing, and maybe a little bit of our objectives for the future. And then we'll be able to hear from a subject matter expert today for a while, and we'll have some time for question and answer at the end. We'll want to let you know that the call is being recorded. You might have even got an announcement about that when you first joined, but we've got you guys all muted at this time just to keep the call flowing. But please feel free to ask a question via chat in the chat function in Teams, or you can raise your hand virtually in Teams and we'll unmute you if we need to do that. But either way, we want this to be interactive, so please feel free to let us know via chat or by raising your hand. So I want to tell you how much we appreciate everybody joining in and being a part of this group to get things off the ground and going. I'm Jay Strickland with Strategic Solutions. One of my colleagues here, Megan Papaleo, is here facilitating, also on the other side of the camera. We are here purely as facilitators to get this group going. Ultimately, you guys all own this group, and we are, if you're not familiar with us, we're an IT service provider that is focused on the healthcare space, and we already are doing business with a lot of you guys that are on here, but our purpose is just to help create an environment where you guys can share information about Allscripts, learn about Allscripts, and network. So really the heroes behind getting this off the ground are the steering committee. We reached out to a handful of people that had expressed an interest in something like this in the past, and I'd like to just introduce them really quickly. Rachel Downey and Mary Beth Culbertson from Dermatology Associates of Virginia, Lisa Boatwright from Richmond Ear, Nose, and Throat, Sharon Smith from Virginia Beach Surgery, Kelly Crisp from Raleigh Medical Group, and Ann Wolf from Affiliated Dermatologists of Virginia. We also have two physicians that are participating in this at times, and Dr. Susie Spatafora from Dermatology Associates of Virginia and Dr. Sujatha Raman from Raleigh Medical Group. So as you can tell, we've got people from Virginia, North Carolina. It's kind of the area that we felt like would be appropriate for people to get to when we can hopefully at some point have in-person meetings. So we thought if we went any further than that, it'd be hard to drive during the course of a day for a day meeting. But anyway, this group of people was instrumental in trying to get at least the framework for this group off the ground initially, and also help us start to figure out who would be interested in something like this and get you guys invited. So just to give you a little bit of idea of some of the objectives that we gathered from the steering committee and what we're using as the basis for trying to get this group started and going. First, we looked at another group that's successful out in the western part of the country, based in Phoenix. They've been running an Allscripts user group meeting for years, and it's grown, and they have a high degree of participation in the area. And so we're taking some cues from that group. They generally have in-person meetings, and they're usually one-day in-person meetings that cover a whole array of topics. But clearly driven by the users and the members of the group, and that's our objective here. So just at a high level, I think everyone on the steering committee, and hopefully you guys would all agree that improving utilization and the education on Allscripts software, specifically professional at PM and EHR, is valuable for all of us. And so that was really one of the key points for the group, as well as providing, as well as kind of aggregating your voices together as a way to communicate things back to Allscripts. I won't name any names here, but one person in particular came up with the idea of having a cocktail party after our first in-person meeting and calling it the unhappy hour, as a chance to be able to vent about things that maybe you're challenging with Allscripts, and then collect those together and communicate back to Allscripts with as a collective user group as opposed to just an individual company. And then finally, probably the most important thing is the idea of you guys getting a chance to network together and share ideas and share thoughts. I know we as a company participate in a peer group that's similar to this, and we get tremendous value out of being able to interact with other peers and bounce ideas off of them in a quick fashion. So we'll talk a little bit more about that at the end of the presentation. You know, when we pulled the steering committee together, we asked a handful of questions really around what type of meetings would be most appropriate. Ultimately, these questions all yielded the idea of really once every 6 month, semi-annual, 1-day meeting, potentially half-day if we can't come up with enough content, but in-person meetings ultimately. Now, with where we are in the pandemic and this time of year and the holidays, we figured getting this off the ground and started with a virtual meeting might be the best way to go. So this is a soft opening, if you will, for the group. So we're, again, really appreciative that you guys are here for it. But we'll be sending out a survey after this meeting and asking these questions again to get feedback from a larger group, from everybody that's registered for this meeting and has expressed any kind of interest in the group at all. So continue to look for feedback from you all. As well, we're looking for you to help us figure out who else would benefit from this group. So if you can be thinking about your other Allscripts, other companies that run Allscripts that you're aware of, other executives that or decision makers in groups that would benefit from this, maybe people that you know from your local MGMA meetings that would have an interest in Allscripts, and as well as potentially getting referrals from other vendors that are out there that might be working in the Allscripts space. So, you know, that is a quick introduction to the group. Megan, you haven't got any questions, I assume? No? Okay, so again, chat is there for any questions that you might have, but we just wanted to give you a quick introduction to where we are. But again, we're going to be asking you for feedback on where you'd like to see the group go over time. So without any further ado, we'd like to bring our first presenter in. We wanted to try and make sure we got somebody that would be able to talk about a topic that would be very important for you all. We have worked with Trisha Conway for a number of years, and I think you'll be able to get a lot out of her presentation today. Trisha's a nurse specializing in healthcare informatics since 2005. She owns eHealth Consulting, which she started in 2014 to help practices navigate technology in everyday patient care. Translating government regulations into understandable and meaningful resources is one of the things that she is known for, and is why she is a subject matter expert for format approved for macro-related regulatory courses. So we're lucky to have Trisha with us today, and without any further ado, I'm going to let her take over and present to you. Welcome, Trisha.
Thanks, Jay. Can you hear me now?
Very well, yes, loud and clear.
Great. Well, it's really nice to be here. I see lots of familiar names in the attendee list, and that's always great. It'd be wonderful to see you guys in person, but since we can't do that, we'll just do our voices as second best thing, right? So please do feel free to ask questions. I have read through those wonderful regulations, that sleeping material that is so wonderful and comes out twice a year. Woohoo! But anyway, so I've read through that. I've tried to translate that into information that's understandable and meaningful to practices as they look forward into not only changes that impact this year, but also next year and into 2023. So I'm going to go ahead and share. And Jay, you and Megan, if you guys see hands raised for questions, let me know, because I don't always see them when I'm talking. So that would be very helpful.
Absolutely, Trisha. We're monitoring both the chat and for hand raises as well.
Thank you. All right. Can you guys see my screen?
Yes.
Okay, so we are headed into year 6 of the MIPS program, where you might be participating through your ACO, which is an alternate payment model. But regardless, we're headed into year 6, so we've got some experience under our belt. In the final rule, they did make some clarifications for 2021, Anyone who is submitting through Part B claims, data completeness, which we'll talk about that definition more as we move through our presentation, does have to be at 70%. And basically what that means is if you're reporting on a quality measure, you need to be reporting on at least 70% of the individuals that meet the denominator criteria. So for Part B claims, it would be the Medicare Part B patients that meet the denominator criteria for that measure. And they actually made that retroactive for 2020, and they really just left it out. So they're now telling you that it matters, and they've put it back into the verbiage of the final rule. A nice thing to hear is that they're continuing to double the complex patient bonus. It used to be up to 5 points, and now it's up to 10 points. And if you remember the scoring at all, and again, we'll go through that as well, that complex patient bonus gets added to your final score at the end. So it's definitely very impactful as it relates to your final score. The other item that you should pay attention to, especially if you are reporting through Part B claims, is that they are suppressing 2 of the Part B claims measures for the hemoglobin A1C and the diabetes eye exam. Now that is only if you are submitting using Part B claims. You can submit those measures through an EHR, you can submit them through a MIPS registry, all that is fine. The CMS web interface, all of that is fine. You just cannot submit them through Part B claims. But we'll dive into later how that doesn't have a negative impact on your final score. So they have made accommodations for that whenever they suppress a measure because there's a problem with it of some sort. The extreme and unusual circumstances, this can be granted for a lot of different reasons this year, especially since we're in the public health emergency. So if you have had any problems this year with, applications to connect to like public health agencies or HIEs, or you've had a problem with ransomware or some type of natural disaster in your area, lots of different reasons that you can apply for an extreme and unusual circumstance. These are pretty much automatically reviewed and approved, and you get an email automatically for 1 or more categories depending on how you fill out your application for an extreme and unusual circumstance hardship exception. Alternate payment models are also eligible to fill out a hardship application for an extreme and unusual circumstance. A lot of times CMS will actually send you a notification that you've been approved for an extreme and unusual circumstance. And as long as you do not submit any data in the categories that you've been approved in, then the extreme and unusual circumstance would take care of that particular category and it will be reweighted. And we'll look more at reweighting as we move through our presentation and talk about 2022 and what the rules are for reweighting if you are exempt from a particular category. The estimated payments based on the 2022 performance period, which you know that whatever your performance year is, payment doesn't actually happen until 2 years later. So when we move into the 2022 performance period, we're talking about the 2024 payment year. Just like when we talk about the 2021 performance period, we're talking about the 2023 payment year. And so what is anticipated, and a lot of this has to do with the increased thresholds for participation, which we'll talk about in a few minutes. You're seeing that the percent of eligible clinicians that get both a positive adjustment and an exceptional payment adjustment is actually pretty low now at 14.5% is the projection. And, you know, that's based on the fact that it's getting harder to achieve the minimum thresholds for reporting. This is the last year for the exceptional payment adjustment, that $500 million that eligible practices, groups, individual clinicians, APMs that are MIPS, APMs have been eligible for, that actually goes away with the 2022 performance year. For the MIPS eligible clinicians, there were just a couple of changes here. The clinical social workers have been added. So if you're reporting as a group and you do have clinical social workers that are part of your practice, they would need to be included in your aggregate group score, which would mean that they need to have an account in the Allscripts analytics platform so that you can include them in your data aggregation for your quality measures. You would also need to be able to include them in your promoting interoperability measures and introduce them to your improvement activities as well. They are exempt if they're reporting as an individual clinician. The clinical social worker is exempt from promoting interoperability, just like a lot of our therapists and nurse practitioners, physician assistants. If they were to report as individuals, they have been exempt for the last few years because they don't have a lot of experience with promoting interoperability. But clinical social workers as new providers in the program do not have to submit promoting interoperability unless they're part of a group that does have to submit it, okay? Certified nurse midwives, they are also new to MIPS this year because they have had a history of having to participate with promoting interoperability like measures. So from meaningful use or even prior to that, they are not exempt from reporting the promoting interoperability category. The low volume thresholds for eligibility did not change. I just included them so that they would kind of all be in the same slide deck, if you will. We're still looking at whether or not a practice or an individual clinician has billed more than $90,000 in allowed charges. They have more than 200 Medicare patients, and they provided more than 200 covered services. So if all three of those things are true, they are required to participate in the program so that they don't get penalized negatively for not participating. The determination period for this low volume threshold is a combination of 2 years. So they look back and they start, because we're talking about 2022 as the performance year, they're going to start in October 1st of 2020 through September 30th of 2021. And then they'll go from October 1st of 2021 into the performance year to September 30th of 2022. Okay, so just like with costs that we're familiar with, they look into the performance year before they calculate the final pieces of that category. If a group or individual clinician does surpass those low volume thresholds and they choose not to participate, they will get a full -9% adjustment to their Medicare Part B payments. Okay. So it's important for people to participate if they are required to do so based on those low volume thresholds. For the collection types, the only thing that has changed here is the CMS web interface has been extended once again. So in 2022, if you're a large practice, you can still use the CMS web interface. In addition to that, alternate payment models that are using the performance pathway, so the alternate payment model performance pathway, that's a mouthful, and the Medicare shared savings programs, they will be able to use the CMS web interface through the 2024 performance period. So they have a few more years to transition to a different way of collecting and submitting data. Even though CMS wanted this year to be the last year, that just wasn't feasible with all the technological changes that had to be made at the APM level. You still have your CAHPS for MIPS survey, so that's not any different. For submission types, again, we still have the CMS web interface like we just talked about, but they added a new submitter type. So for submitters, we've got individuals, groups. We now will have subgroups starting in 2023. And we'll talk more about what a subgroup is, because you'll need to start thinking about it and getting prepared for 2023, maybe not first thing in January, but it is something that we're gonna have to plan for, just like we will the MIPS Value Pathways that we're gonna get to towards the end of the presentation, and how subgroups will play into that implementation as well. With subgroups, they look at those based on specialty group. You can have two different types of specialties that they defined in the final rule. One is a single specialty, that's pretty self-explanatory. The other would be a multi-specialty, which is a tax ID that has two or more specialties that fall underneath it. You can have multiple specialty groups or subgroups is what this will ultimately end up being underneath one tax ID number. So more about subgroups, like I was saying, it doesn't actually go into effect until 2023, and it will be in effect for both the MIPS Value Pathways, which will start in 2023, and the Alternate Payment Model Performance Pathways. If you're participating in a MIPS Value Pathway, there will be a registration process for that, so identifiers can be assigned, and so it's clear to CMS who is participating in that MIPS Value Pathway and who isn't in the group. But for subgroups that are participating through the Alternate Payment Model Performance Pathway, they will not have to register. When you're looking at subgroups and specialties, 75% of that subgroup must be in the same specialty. And then reweighting can occur for the specialty or for the subgroup, I'm sorry, just like it can for a group or an individual submitter, as long as they qualify either through a reweighting scenario or if there's a hardship. The only exception to that when you're in the MIPS Value Pathways is that you cannot ever claim an exclusion for the quality measures. There is a relationship between the parent and the subgroups. So the parent brings to the equation the eligibility status. So whether or not the group meets the low volume thresholds and the group is required to participate in MIPS or in an alternate payment model. If there's a special status like a healthcare provider shortage area, or a non-patient facing, some type of special status in that grouping, then that would carry over from the parent to the subgroups. If there's an approval for a hardship exception, that also flows from the parent over to the subgroups automatically, as well as the aggregate numbers for promoting interoperability. So all of those things are going to flow from the parent to the subgroup. The subgroups would be responsible for quality, cost, and improvement activities. All right, so they've got those three things, and then the parent is responsible for the rest. In 2022, so we're going to switch gears again. The final score, the threshold that you're trying to meet so that you at least get a neutral payment adjustment, is 75 points. If you want to be part of that exceptional performance grouping that is eligible for the 500 million, you have to get greater than or equal to 89 points for your final score in order to be in that pool of the 500 million pool. Is that like the winner's circle or something like that? So you've got that 500 million for exceptional performers. And again, 2022 is the last year. So you want to make sure that you take advantage of it this year. For the performance categories, the breakdown is quality and cost now have an even split. So quality is 30% that goes towards the final score. Cost, 30% of that goes towards the final score. And then improvement activities and promoting interoperability are still the same at 15% and 25%. The reporting periods have not changed. And when you're looking for your performance feedback report so that you can get your data for cost and you can review what type of information might be published on the physician compare related to your quality measures and the other things that you've reported for MIPS, you're going to look for that performance feedback report in July of the performance year. So like in July of 2022, the feedback report will be based on the data that was submitted for 2021. If you have not already looked at your performance feedback report for this year, I would encourage you to go ahead and do that because you still can give some input on what would be published in the Physician Compare website. Again, just the breakdown of scoring. We talked about MIPS. If you're reporting through an alternate payment model performance pathway, and right now there's just not many people that are doing that, your quality is 50%, your improvement activities are 20%, and then promoting interoperability is 30%. So what happens is they take that cost because it's kind of inherent within the alternate payment model, and they split that up between quality and improvement activities and promoting interoperability. And then for the MIPS APMs, they would get 55% of their score would come from the quality, 15% from improvement, and then 30% from promoting interoperability. So for our quality performance category, and I'm just kind of going to hit the highlights here because there's not a lot of stuff that has changed in quality. But still impactful. So you've still got those 6 measures, one outcome measure or another high priority measure. If you can't find an outcome measure, your CAHPS for MIPS does count as a high priority measure. So we've got those rules that still go into play. With the CAHPS for MIPS survey, they are taking into account now whether a patient may have already received a CAHPS survey from an in-center hemodialysis unit, and then they would exclude those from getting an additional survey of the same type within the year. And then they also have provided an Asian language-based survey to meet that population. There was a change in the 7th measure. So if you're a large practice, meaning that you have 16 or more clinicians that are part of your group, this used to be the hospital-wide 30-day all-cause unplanned readmission rate for ACOs, and now it's the one for MIPS. So they just kind of switched that up a little bit. And then there is a 200 case minimum. If you don't meet the 200 case minimum, then you would just be scored on 6 measures. So you wouldn't be penalized by not being able to report that 7th measure. You would just be scored on the 6 instead. And that's the same concept if a measure gets suppressed. Let's say that you have 6 measures and 2 of them get suppressed. You would only be scored on 4 measures total as opposed to the 6, so that you wouldn't receive any penalty for the fact that those had to be suppressed. So this is that new measure. I'm not going to spend time here. I just put it in here so that you would know where to find it. In the 22 quality measures, we have 200 measures that are available to us this year. They did add 1 measure for ECQMs, which is your EHR-based reporting. There were 2 measures added for MIPS CQMs, which is registry reporting, and then 1 measure that was added for administrative claims. And so we'll go through that. There were 87 measures that have substantive changes. So I would encourage you that whatever quality measures you are using for the performance year, that you do review the specifications so that you make sure that you're measuring the right thing. With the submission types, there is an APM entity, which was introduced first last year. But last year, there were very few people that actually reported using the alternate payment model performance pathway. CMS set this up so that it would be a decrease in burden on practices that are participating in APMs, but they underestimated quite a bit, actually. I think the technical challenges to implementation of this. And as a result of that, the CMS web interface is still available through 2024 to accommodate for those challenges. So most of our APMs, which is kind of synonymous a lot of times with ACOs, are still using that CMS web interface as a means for reporting, as opposed to submitting through like a registry or through the EHR, or perhaps even using a qualified clinical data registry. By 2025, though, they must transition. So, you know, they are giving them a grace period that's pretty significant, but by 2025, definitely they must be able to do the 3 ECQMs. And a lot of that just has to do with the fact that they can't maintain the web interface forever. These are the web interface measures. They haven't changed. Just want to call out that measures 134, which is the preventive care and screening for depression and follow-up plan, 370, which is that depression remission at 12 months, and 438, which is the statin therapy for prevention and treatment of cardiovascular disease. Those are not actually scored against a benchmark. They're just measured on whether or not you're able to report them. These are the APM measures. So we've got the diabetes, hemoglobin A1C, preventive care and screening for depression and follow-up, and controlling high blood pressure would be the ones that are actually reported. And then the other ones are administrative claims measures, and then the CAHPS for MIPS survey. Any of these reporting methods that you choose, you do have to think about data completeness and, you know, the population of patients that you're reporting on, whether it's all payers or Medicare Part B only, and whether or not you are meeting that minimum requirement. So for the CMS web interface, you have to report on 100% because it's a certain number of beneficiaries. Administrative claims, it's always 100% of your claims data. For all of the other measures, it has to be 70% of the patients that meet the denominator criteria. They did talk about raising this to 80%, but decided not to do that. So it will still be at 70%, not only for 2022, but also for 2023. Keep in mind, though, that if you do happen to switch EHRs in the middle of the year or know someone else who's switching EHRs, make sure that they understand that just because you switch doesn't mean that you don't have to calculate for data completeness. So if I switch in June, you know, chances are I'm going to need to aggregate my data across 2 different EHRs to make sure that I am meeting data completeness. So, you know, the very important thing to keep in mind, because I know that there's a lot of mixing up going on right now. And so it's really important to understand that data completeness is key in making sure that your scores stay high. This is a grid just to help you understand the different quality measures. Some of them have benchmarks, some of them don't. Some of them you may meet the case minimum for or not. And then data completeness, is that met? So you basically got 3 criteria to look at when you're looking at a quality measure. So if a quality measure has a benchmark, you meet the case minimum, which is typically 20, but not always. And that's why it's important to look at the specifications. And then if you meet data completeness, you're looking at a score somewhere between 3 and 10 based on the benchmarks for that submission type. For the second one, if you have a benchmark, but you don't meet the case minimum and you do meet data completeness, then your floor is 3 points for that particular measure. That's the highest score you can get if you don't meet the case minimum. Similarly, if you do not meet data completeness, small practices have a floor of 3 points, whereas large practices that do not meet data completeness for the measure that they submit would not get any points at all. They did something really cool, though, for new measures. If you choose one of the new measures that have been introduced that first year, even if there's not a benchmark and you don't meet case minimum, you can still get 7 points in the first year that a new measure is out by participating in that measure. And then similarly, in the second year, you can get 5 points as a minimum for participating in that quality measure. If there is a benchmark and you meet case minimum and data completeness, then your score on a new measure for the first year would range from 7 to 10 points. And in the second year, it would be 5 to 10 points. So real incentive to use some of those new measures. They talked about this hierarchy that they were going to use for calculating benchmarks, and they ended up having enough data to be able to calculate benchmarks from the 2020 performance period. So we will see a new benchmark spreadsheet come out probably before January, and that does tend to change sometimes throughout the year. Like I think we got one in August, or maybe even later than that for this year. So they do change, but for the most part, they're set before the performance year. A lot of this is the same, but big thing that I want to point out at the bottom here, bonus points are no longer available. So we're used to having bonus points if we do additional high priority measures or if we choose additional outcome measures, and there are no longer any bonus points available for that. We're also used to having bonus measures if we use end-to-end reporting, meaning that the data is documented and calculated in the EHR and then is reported directly through a registry or the EHR to CMS. And those bonus points are no longer available either. So that's a bit of a hit in the quality performance category because you could easily get your minimum number of bonus points or hit your maximum, let me put it that way. You could easily hit your maximum number of bonus points by just those two options. So we're going to have to make sure that with the quality measures now that we're implementing the right workflows and we're still getting our high points, but we're not so dependent on bonus measures to get there. All right, so quickly with the new quality measures, this is just what I was talking about with that graph with the new measures for the first year and the second year. And then just to go through the new measures really quickly, this is the first one for the EHR, which is the intravesical, bacillus calmate garin for non-muscle invasive bladder cancer. It's a mouthful too. One of the registry measures is the hemodialysis vascular access measure. And then this is a new measure, and this is a registry measure, person-centered primary care measure, patient-reported outcome performance measure. This is a survey that gets sent out, and the case minimum is based on how many providers you have. So it's either 30 per clinician, or if you have 5 or more clinicians, it's 150 minimum for the group. So, this is why it's important for you to look at those specifications because we're so used to it being 20. And this measure, the clinician and clinician group risk standardized hospital admission rates for patients with multiple chronic conditions. So this is the other administrative claims measure, and this one actually has an 18 case minimum. So you might want to take a look at those 4 new measures, see if there's any you want to participate in, especially if having those 7 to 10 points or just even the 7 points would be advantageous to you in reporting the quality score. This just reviews some of the information about substantive changes and what makes up a change. And again, they can either shorten the reporting period or they can suppress the measure depending on whether a change has been made that falls into those categories. There were some measures that were removed in 2022, and so I've highlighted them in green if it wasn't finalized in the final rule. Okay, so green means that you can still use them. So for example, for age-related macular degeneration, the claims measure was removed, but the MIPS CQM is still available. The diabetic retinopathy communication with the physician managing ongoing diabetes care, they left that one in, okay? Those other 2 they took out, those were taken out except for The melanoma continuity of care recall system, which a lot of dermatology practices use, that one was left in for 2022. Oncology, the medical and radiation plan of care for pain, that one was left in. And then these other ones that are on the list were taken out. This is just a reminder about your performance feedback report, how to access that, and it does give you good information on quality and cost measures. Cost for the 2020 reporting year was actually reweighted for everyone. That's not the case for the 2021 reporting year, even though there's a lot of people that may not meet case minimums, and they may be reweighted in the cost category for that reason. It's not like a global, nobody's going to be scored on cost like it was in 2020. Okay, so let's talk about cost. Cost is 30% of the final score. The benchmark will be based on the performance year, so we won't actually know what our cost numbers are going to be until July of 2022. So it is kind of late in the game, but at least they tell us before the reporting year is completely over. So, you know, that's when we'll look for our cost measures. They did add 5 additional measures. So let's look and see what those are. These are the old ones. And then these are the new ones. So we've got asthma with chronic obstructive pulmonary disease, diabetes, colon and rectal resection, melanoma resection, and sepsis. So we've got 5 new measures, and they also introduced a call for cost measures so that they could start getting in more suggestions for cost measures to line up with the MIPS value pathways that they're trying to implement. Cost measure attribution. Again, each cost measure has a specification document, and I would encourage you, when you look at the titles of the cost measures, if you feel like one of those is going to apply to your practice, take a look at that specification to see whether or not you are going to have patients attributed to you, because the case minimums are pretty low. For one of the new measures, the chronic disease measure, a triggering event is actually defined as, and this is just an example of one of the specifications, when a clinician bills an E&M charge for 2 visits in close proximity. That would open a 1-year attribution period for the clinician. If you've got multiple clinicians that are billing services for the same patient, the patient is attributed to the clinician with at least 30% of the services that are billed. Basically, whoever bills the most is the one who the patient's going to be attributed to. They also take into consideration, only with the chronic disease measure, whether or not the clinician is writing prescriptions for the chronic condition in addition to providing those services. So like I mentioned, each of the cost measures actually has a specification document that explains those triggers in great detail. All right, improvement activities. 15% of the score for MIPS, 20% for the MIPS APMs, or alternate payment models. You get full credit if you are a patient-centered medical home, or if you are participating in an alternate payment model performance pathway. So that's great news. If you're participating in CPC Plus in 2021, or you're going to participate in Primary Care First, which is taking the place kind of CPC Plus, then you would get full credit for the improvement activities. When you select improvement activities, at least 50% of the providers in the group, or the eligible clinicians in the group, must participate in the improvement activity. So the improvement activities must be the same, but they can have different reporting periods within the calendar year. So you might have, one specialty that does it at the beginning of the year and another specialty that does it at the end of the year. And as long as it's the same improvement activities, then that's completely okay. There's 7 new ones. We've got 15 that were modified and then 6 that have been removed. The new ones have a lot to do with health equity across the spectrum, as well as making sure we take care of our clinicians that are providing care. You'll see that one in the middle there for promoting clinician well-being. which is a great one because, you know, with the pandemic and telehealth and, you know, decreases in staff due to multiple reasons, it's been a really tough couple of years on our clinicians. So we need to make sure we're taking care of them. For the call for improvement activities, which was defined a couple years ago, they did just add some new criteria. So if you're submitting an improvement activity, you might want to take a look at these.
Can you still hear me? I had to switch audio devices.
So Trisha, you're a little bit muted. You sound a little bit far away, but we can kind of hear you.
Just a second. Can you hear me now?
Much better.
Awesome. Okay. I just wanted to make sure I didn't like completely die. Okay.
Well, Trisha,
so
I'm sorry, Trisha. While you're paused, I know you have, I think, one more slide in this section. But just if I can just say real quickly, we've opened everybody up so you can unmute yourselves if you have questions that you want to ask Trisha interactively. And maybe Trisha, I think there's a break in your slides coming up. Maybe we could stop and see if anybody has any questions at that point.
Sure, absolutely.
Great, thank you.
You bet. Okay, so again, just some selection criteria I wanted you to be aware of if you were going to submit improvement activities. The following were removed. A lot of these were considered duplicate or they just didn't really apply anymore. Programs that had been discontinued, so things like that they consider for removal of improvement activities. Okay, so before I start promoting interoperability, are there any questions? All right, well, hearing none, we will keep going. So certified EHR technology. Right now, most people are using technology that is certified to the 2015 certification criteria. There are new certification criteria for EHRs. It's called the 2015 Cures Act or Cures Update certification criteria. And so EHRs are working towards that. Those certification criteria include a lot of things about electronic document exchange and expanding capabilities with interoperability, making the FHIR connectivity, FHIR fast healthcare interoperability resources, that application programming interface more available to third parties and smart apps so that, you know, there's a lot more integration that can go on. So a lot of the new certification criteria was centered around that, information blocking, all those kinds of things. One of the nice things that they did with the final rule is that they decided that small practices no longer had to actually submit an application to be reweighted in the promoting interoperability category. Now, a lot of practices, which a lot of you on the phone, I know for a fact, do really well in the promoting interoperability section. So you wouldn't want it to be reweighted for you. But for others that either struggle or maybe their EHR technology is not able to connect through and provide the functionality for patient access or for the health information exchange or electronic, supporting electronic referral loops, exchanges with public health agencies, immunization registries, etc. So EHR technologies that don't do a great job at that, a lot of times practices, you know, every year they have to remember to submit that hardship exception. So no longer do small practices have to do that. They will automatically be reweighted as long as they do not submit data. So anyone who submits data, and regardless of whether it's promoting interoperability or any other category that they may have previously been excluded from, that trumps the exception. So you submit data, you will be scored. That's kind of the bottom line there. As far as the measures go, not a lot of changes here. They did keep the query of prescription drug monitoring programs as a bonus measure within the ePrescribe objective, and that is still worth 10 points. So if you are participating in EPCS, electronic prescribing of controlled substances, as long as you query the PDMP at least once during the reporting year prior to prescribing an electronic prescription for a controlled substance, then you will get that 10 bonus points for your group. So that's great. You should all be connected with that now. If you're not, then you should log a ticket so that you can be. Down with the patient exchange, so there was a proposed item there, which you may have heard about, which would have required you to keep all of the data that you exchanged with the patient portal from January 1st of 2016 to infinity, and they decided not to move forward with that. So that was a pretty key element there, because that really would have been a nightmare. There was a big change, though, with the public health measures, because now we've got 2 required public health measures, which immunization registry reporting and electronic case reporting are the 2 required measures. And if you meet those required measures, either through active participation or because you can claim an exclusion, then you would get the 10 points for the public health area. If you also, in addition to those 2, if you also do another 1 or more of the public health reporting options, you can get up to 5 more points. So it's not 5 each, it's 5 points regardless of how many additional ones you might do. Another item that they added to the promoting interoperability section was related to the security risk assessment and a subsequent requirement that the practice complete a safer guide for high priority practices. So with this safer guide, you have to attest yes or no that you have completed a safer guide, and your attestation, regardless of whether it's yes or no, does count for addressing that requirement and would allow you to move forward in the promoting interoperability category, just like if you've submitted or completed a security risk assessment and indicated yes to that measure, you were able to move forward with promoting interoperability. So this is an example of the SAFER guidelines, and I'm not going to read all this to you, but I put it in here so that you can take a look at it. It is the SAFER guide for high priority practices. There are a lot of other ones, but this is the only one that you have to address at this time. It's a yes or no attestation as a group that yes, we've completed it, no, we haven't completed it. There is an answer required, as I was saying, but what your answer is doesn't impact your score. So if you say no, it's okay, you can move forward. They do want you to complete these high priority practice screens, and they're not very difficult. And the suggestion is that you pull together a team of people. So you've got representatives from your clinical group, allied health staff, IT, any external partners that you may have, and then complete that assessment together. And then at the end of the assessment is where you would actually list all the your tax ID and all the MPIs that are participating with your group so that they can give credit accordingly, or so that you have the documentation to back that up. So these are just some of the questions, and they're kind of all over the place within this assessment. So your first one is data and application configurations are backed up, and then you look at the 1.3 and it's allergies, problems, and diagnostic tests, including interpretations, are entered and stored. So, they do bounce around a little bit, and you can see why it takes a team approach to answer some of these questions. Each question has more information, so if you need some help, you can break out into more information about an individual question. And so then it just keeps going through all the questions that are included in the SAFER guide for high priority practices. So again, I'm not going to read this to you. I just wanted to include it so you'd be able to see it. With the prescription drug monitoring program, CMS does want to make this a required measure. They may do so as early as 2023, but they also want to make sure that each EHR has had the opportunity to implement and integrate prescription drug monitoring into their platforms. And as a result of that, CMS has actually started developing their own PDMP, which is called RX Check. It's in the early prototype testing, which is why they couldn't make PDMP a required measure for 2022, but they are hoping to get it finished. Regardless of that, though, all 50 states do actually have a tracking system. It's just a matter of what their ability is to connect to other entities and report that information out. The CMS application is based on the FHIR standard so that it can be more available to all types of EHRs that are compliant with FHIR standards. We talked about that. With patient access, one of the things that providers had to attest to when they were submitting promoting interoperability is that they're not, and I'll get to it in a minute, but they're not knowingly and willfully preventing information from being shared. And, you know, a lot of the information blocking was talked about in the ONC 21st Century Cures Act, and exceptions to when you had to share information, when you didn't have to share information, and all of that has been considered and incorporated into the new ONC Cures Act certification requirements for the EHRs. So you'll see that come out when they release, when any of the EHRs release a version that is compliant to the 2015 Cures update. The implementation of that United States core data set for interoperability, which just basically means that everything is coded so that if you document a clinical summary that you can send it to another EHR vendor and they can import that information and it'll be discrete data. We get some discrete data now when we import, but it's not nearly as good as it could be if we were all speaking the same coding language. With the required measures, we're all very used to the immunization registry, not as much with the electronic case reporting. And that's one of the reasons why they added a fourth exclusion for the electronic case reporting. So a lot of times you're going to see that abbreviated as an ECR. There are 120 diseases that can be reported through electronic case reporting, and all 50 states have the ECR available. It's a matter, again, of whether or not your EHR technology is able to connect with that public health agency and whether you can get that hooked up before your reporting period begins, which is pretty much impossible for everyone unless you can do it in the next 29 days here. And then the remaining three measures, as we just talked about, are optional and eligible for bonus points if you are participating in any of those. The idea with the electronic case reporting is that it's a bi-directional exchange between the practice and the public health agency. And that's one of the things that makes it so difficult for the EHRs is that bi-directional exchange. So I can bet that the majority of people will be claiming an exclusion for this measure this year. And that fourth exclusion is that you're using a certified EHR technology that either hasn't certified to the electronic case reporting prior to the start of the performance period selected in the reporting year for 2022. So, you know, that's going to be pretty common throughout all the people that are submitting for promoting interoperability. The reweighting hasn't changed. Again, I just left it in here so that it would be readily available. But basically, if you're excluded from one of the objectives, then those points get transferred to another. So e-prescribe, if you're not prescribing more than 100 prescriptions during the reporting period, then your 10 points would be split between the supporting electronic referral loops, sending of information or receiving of information. So that's just an example. This is another one that hasn't changed, the non-patient facing providers. Again, I just left it in here so that you would have more of a comprehensive handout related to MIPS. The attestation statement that was left in, so out of the 3, this is the only one that still remains, and it's the one that I just said. A healthcare provider must attest that it did not knowingly and willfully take action to limit or restrict compatibility or interoperability of certified EHR technology. And these are the 2 that were there that have now been taken out. So calculation of the final score, again, not something that's really changed other than quality is 30, cost is 30. And then the complex patient bonus, the way that that is calculated got really complex. And so the calculation is now based on a medical indicator, which is based on your HCC code documentation, your hierarchical condition category codes, and a social indicator, which is based on whether or not your patient is dually eligible, so meaning they're on Medicare and Medicaid, in addition to their age, gender. So you've got 2 different indicators that are considered for the complex patient bonus. The eligible clinician or group must meet one of those indicators underneath the complex patient equation in order to be eligible for the complex patient bonus. And then, once they're eligible, then those 2 things would be calculated, and it is a complex calculation. I do have the details. If you're a math whiz and you want that information, I'd be happy to send it to you. But it does get very complicated. As long as you meet the criteria for one, they calculate both, add the 2 together, and then use that to determine what your complex patient bonus is, somewhere between 0 to 10 points. Okay. This is a grid about what happens if you have to be reweighted. So for example, if we have a large practice that needs to get reweighted in the cost category, then their qualities, this is the 3rd line in, or the 2nd line with data, they would get 0 in cost, and 25 of those points would go to quality. So quality would increase to 55%. And promoting interoperability would increase from 25% to 5%. So, they want it to stay as a calculation of 100%. So if you are going to get 0 in a particular category, they're going to move those points around until they're distributed so that it's 100% of the categories that you're eligible to participate in. They split out the small practice from the large practice. I think I just skipped a slide. Or maybe I'm just going backwards. There we go. So the small practices were split out. And so you can see on the 2 lines that this has an impact. So the first one that's highlighted, if the practice doesn't send in any information for promoting interoperability, remember they're automatically excluded unless they submit data, then their categories would fall out as follows. They would get 40% of their final score from the quality measures, 30% from the cost measures, and 30% from the improvement activity measures. All right, so payment adjustments, depending on how you score. So if you get 75, remember that's the threshold, which gives you a neutral adjustment. Anywhere above 75 up to 88.99, you're going to get a very small positive MIPS payment adjustment. And then if you're above 89, then you fall into that additional payment adjustment for your exceptional performance. That percentage should be a little bit higher for the 2022 performance year, simply because the score requirements have gone up and there won't be as many people participating. This is just a reminder of the APMs and how their scores are a little bit different than traditional MIPS because the cost is rolled up into the concept of being an alternate payment model. Here is the list of the approved advanced alternate payment models for 2022. There's a couple of new ones in here, the global and professional direct contracting model, and then the primary care first, which is replacing the comprehensive primary care model. Another reminder about the alternate payment model performance pathway, the 3 measures that you would submit, and then the 2 claims measures and the CAHPS for MIPS survey. They're still encouraging participation in this, but you do have that fallback plan of the CMS web interface. The Medicare Shared Savings Program participants are required to participate in the alternate payment model performance pathway starting in 2025, and then subgroup reporting is available starting as early as 2023 if groups want to start with that. The concept of having submissions under multiple tax ID MPI combinations, so if a provider went from one practice to another practice during the year, you know, what was the hierarchy for paying that out? It used to be really complicated, but they simplified it significantly. Basically, if you are part of a virtual group, that trumps everything. Otherwise, you're going to get the highest available score of all of your submission methods. So if you submit using an alternate payment model, performance pathway, you submit as a group, you submit as an individual, whichever score ends up being the highest is the one that will impact your tax ID MPI combination for reimbursement. For facility-based clinicians, it's actually similar. They can take the quality and cost from the facility, but if they want to report through a different method, then whichever is the highest score would be what their payment adjustment would be as well. So same thing applies to them. We are looking at a possible sunset date of MIPS in 2027, meaning that they're hoping that a full transition to the MIPS Value Pathways will be able to occur by 2027. So before I start talking about MIPS Value Pathways and just giving you some highlights of what that looks like for 2023, let me ask again if there are any questions about what we've talked about so far. All right, somebody at least tell me that you're still awake.
We're definitely still here, Trisha.
Well, that's you, Jay. Can somebody else tell me that they're awake?
Trisha, we do have a question coming in from Kelly. Kelly, go ahead and unmute yourself and ask the question.
No, I was just raising my hand to say I'm here and listening.
Oh,
Hey,
okay.
hey,
All right.
Kelly.
Hey, Trisha, how are you?
I'm great. It's great to hear your voice.
You too.
Well, thank you for not being asleep. Okay, I know this is really dry stuff, and so, you know, it's tough. But anyway, we'll keep forging ahead. All right.
Hey,
so
Trisha, this is Tammy Hankins. Thank you, as always, for providing such informative information. So we really appreciate it.
Thank you. It's good to hear you too. All those favorite voices out there. It's always nice to, and it'll be great when we can do this in person too. I really look forward to that. All right, so MIPS Value Pathways, new concept. They introduced it last year. There wasn't a lot of framework around it. They kind of had a goal that they were moving towards, but they have defined it in this final rule for 7 MIPS Value Pathways that they're going to support starting in 2023. So that's looking pretty exciting. Basically, an MVP participant, because they have to define this, is anybody who submits an MVP and is assessed and scored on one. So that's a pretty simple definition there. And I think that you'll find if there are MVPs that apply to your practice, that it really is an easier way to draw focus to your specialty, and also to reduce the burden of reporting. So there are definitely some good things about these MIPS value pathways. So from 2023 to 2025, they're optional. So they can be reported by individuals, by a single specialty group, a multi-specialty group, a subgroup, or by an APM entity. Starting in 2026, multi-specialty groups must actually create the applicable subgroups within that parent practice for MVP submission. So CMS really wants this to be personalized to each individual specialty that is part of a practice. And that's one of the reasons why registration will be required for the subgroups that are going to participate in the MIPS value pathways. And also, since the MIPS value pathways are optional to begin with, it's important that practices be able to say whether or not they want to be measured on one or not. So we have 7. We've got one for rheumatology, stroke care, advancing care for heart disease, optimizing chronic disease management, which pretty much applies to a lot of different practices, adopting best practices and safety for emergency medicine, improving care for lower extremity joint repair, and then the support of positive experiences with anesthesia. So they started with these 7 because of the practices that have attested to MIPS in the past or been part of an APM. They started with these because they were most comprehensive to represent those entities. And then as we get to the end, we'll see the list that they're planning to focus on next. This is just a guideline of the registration timeline. I understand that we're talking about 2023, and we have 2 sets of regulations to come out before then, the proposed rule for 2023 and the final rule for 2023. So we can definitely expect some changes, but for the most part, they're asking that people register by April 1st of the performance year to say that they are going to participate using a MIPS value pathway. And then if you're gonna, because you have to submit the CAHPS for MIPS survey, you have to designate that by June 30th. And then the final date that you can make changes to your MVP, because you do have some selections within that MIPS value pathway, the final date to do that would be November the 30th, okay, as well as to change your tax ID NPI participants. The final date for that would be November 30th, okay, of the reporting year. This is just a general guideline of the reporting requirements. So within a MIPS value pathway, you would select 4 quality measures. One of those would be an outcome measure or high priority measure. We're really used to that by now. And then in addition to those 4, we've got a population health measure that we're going to look at as well. For improvement activities, you actually get double points in this area, kind of like a small practice would, so that if you do 2 mediums or 1 high, you're getting the maximum number of points for improvement activities. The cost measures, you are only scored on the ones that are part of the MIPS value pathway. So even if you qualify for other cost measures, if you're participating in a MIPS value pathway, those other cost metrics would not apply to you. It's only the ones that are part of that MVP. As I said, there's the population health measures, and then the foundational piece is the promoting interoperability performance category. Okay, so that we looked at a pyramid last year, and I meant to stick that back in here as well, but you've got promoting interoperability on the bottom, and then everything else stacks up on that. So I wanted to look at an example, and I picked the improving care for lower extremity joint repair. So these are the quality measures. We've got 7 of them. So from these 7, we would need to pick 4. And you can see at the end where it specifies whether it's a MIPS CQM measure, which means that it's a MIPS registry, or it's an eCQM, which means that it can be reported by an EHR, or if it's claims-based, so you can, or administrative claims. All right, so you've got all that information here for you. And then the exclamation points are whether or not they're high priority. Double explanation means that it's outcome, and then the star would mean that it's a existing measure, but they've had a lot of revisions to it. Okay, so that's kind of our code for those symbols up there. But a lot of these measures an orthopedic practice would already be doing. So the, total hip or knee replacement, functional status assessments, preventive care and screening for BMI. A lot of these are already being addressed by orthopedic practices, which could be who would be participating in this MIPS value pathway. So again, this is just a recap of what they're looking at. If you have a scenario where you've got a multi-specialty group and you've got an MVP, you must have a high priority measure that's applicable to each of the specialties that's represented in the participant group. Okay, so let's say that you were doing, chronic disease management, and you had primary care participating, and you had endocrinology participating, and you had nephrology participating. Then you would want to make sure that you had a measure that was applicable to each one of those specialties. For the improvement activities, so we've got to pick 1 high or 2 mediums, and we can tell here which are the highs and which are the mediums. And so, regular training and care coordination might be 1. Use of evidence-based decision aids to support shared decisions making is a fairly easy one to follow through on. And then there was another one here, that consultation of the prescription drug monitoring program. So before you do electronic prescribing of controlled substances, are you consulting a PDMP? And that's a high priority measure. So if you're doing that one, then you've already met the requirement for this category of the MIPS value pathway. Cost measures, the ones you would expect: elective primary hip arthroplasty and knee arthroplasty. So if you did happen to meet the criteria for the total per capita cost or the Medicare spending per beneficiary, that wouldn't matter because those 2 measures are not part of the MIPS value pathway. The population health measures, and so you have to choose one of these. One is the hospital-wide 30-day all-cause unplanned readmission for MIPS, and the other one is the risk standardized hospital admission rates for patients with multiple chronic conditions. So both of those are measured by administrative claims. Now, the population health measure could actually count for your outcome measure. However, if you don't meet the case minimum and you haven't chosen another outcome or high priority measure, then you're kind of in a hard spot. So just be careful about that. With promoting interoperability, it's the same measures that we just talked about. It's just this is the foundation of the MIPS value pathway. In 2023, they are not allowing opt-in eligible clinicians to participate in the MIPS value pathway. It has to be a group whose parent has met the eligibility requirement and is required to participate in MIPS. All right, so no voluntary reporters, no opt-in reporters, no virtual groups starting in that first year. They want to try to keep it pretty simple. This is just, we saw this slide earlier, but it was also important here that we remember what the parent brings to the table when we're breaking up the MIPS value pathway groups into subgroups. The MVP scoring is very similar to the scoring that we see with regular MIPS. So we've still got our quality measures. We've still got our cost measures, our improvement activities, but you're just getting double credit if you do a high weighted or medium weighted. So that's all the same. You've got that one population health measure. And then the promoting interoperability. The promoting interoperability is actually aggregated, like we talked about, at the parent group level and then trickles down to be applied to the subgroup. If the group, the parent group, is excluded from promoting interoperability, then that hardship exception also applies to the subgroup. So, that goes back and forth. It's just a reminder of those measures. Just try to put them everywhere so they'd be handy. The MVP scoring, again, CMS is looking to reward the highest score regardless of how you submit information, whether it's through an MVP, whether it's through an alternate payment model performance pathway, as an individual clinician, as a group, it doesn't matter. They want you to get the highest possible score that you can for your payment adjustment. With the parent group final score, just a reminder that the MVP participants are still included in the group final score. They're still part of that parent group, even though they are also reporting as MVP participants. So the list of clinicians that are registered for the MVP, they would also be on the list for the parent group when the parent submits their information for MIPS. It's similar to CPC Plus. If you've got part of your practice that is participating in CPC Plus, and then you've got specialists in a multi-specialty scenario where your specialists are not part of CPC Plus since it focuses on primary care. For CPC Plus reporting, you just use the providers that are part of that program. For MIPS reporting, you use everyone. So it's the same concept if that's a concept that you're used to. But with MVPs, that parent group is going to include everyone, and then the subgroup, when they're reporting on quality, cost, and improvement activities, it would just be their information. Future focus, and we just have one more slide to go, is going to be in these areas. These were the next largest areas for submission that they wanted to focus on after they got those initial specialties out of the way, because they really felt like the specialty reporting was lacking. And then just, a reminder, our guiding principles of MVPs, we want to make it simpler, more concise, and, make it so that many different practices are easily able to participate in the MIPS Value Pathway program so that they can sunset MIPS. All right, the real question slide. So does anybody have additional questions?
Trisha, wow, that's a lot of information.
It is a lot of information. And believe it or not, I actually cut it down.
I know, you told me that. But I think the key is that, I've seen a number of MIPS presentations. That was the most clear-cut, easiest to understand, very definitive. So thank you for that. That was I'm sure everybody here feels like that was really valuable.
Well, thank you. I appreciate that. It's definitely my goal.
Well, we definitely have some time for questions here. Any of you guys can unmute yourselves and ask questions directly. Anybody out there have any thoughts? I'll kick it off with a question, Trisha, if that's all right. Maybe that'll spur some others here. But I know obviously you have deep expertise in this MIPS in general and some of these topics we talked about today. But I know you also have a deep understanding and a lot of experience with Allscripts. So I'm wondering, can you point out one or two things maybe where Allscripts where it's challenging to get particular items of this out of Allscripts in particular, or maybe some tips and tricks for our Allscripts audience here on things that they should know specifically related to how Allscripts users can pull the key information?
Sure. So Allscripts has actually already published their workflow guides for the 2022 clinical quality measures. So you can look for those out on the website. And so, for the quality measures that you're doing, you need to read through those specifications if you're not working with, a third party to understand those. You really need to make sure that you understand them, that you educate your providers, and that you customize the system to make it as easy as possible for them to be successful. So if that means, creating a part of a short list that's specific to the quality measures, putting little folders in there that give them instructions, if this happens, then document this. If this other thing happens, then you need to put this code in the assessment and plan. Your understanding of the quality measures and customizing the system effectively is really key to their success. So that would be one thing. A second would be that really pay attention to your reports in the Allscripts analytics platform, because they are not always accurate. I would encourage you to audit your results, whether they're low or high. You can still audit them to determine whether everything is being picked up that needs to be picked up in your reports. And, you can, in some practices, they actually use those reports to encourage some friendly competition within the offices amongst providers to get their scores up. So, that's another thing that can be really handy.
Yeah, gamification of MIPS, right?
Mm-hmm.
Well, great. Well, thank you. Any other questions? Teresa put a comment here thanking you, Trisha. I think this has been very valuable. We really appreciate it, Trisha, and we appreciate you being our inaugural speaker here for this Allscripts user group meeting.
Happy to do it. I appreciate the opportunity.
Yeah. So if there are no more, I like the little clapping hands. So if there are no other questions specifically for Trisha, I'd like to open it up just for a few minutes and see if anybody has any thoughts or suggestions for the group as in general, maybe around future topics or framework for the group. Again, we'll be sending a survey out that you guys will have a chance to think about a little bit and respond more later. But I figured since we're all together and we've got a few more minutes, I'd love to see if anybody has any Allscripts questions in general that you might want to put out there for the rest of the group, to see if anybody has any thoughts or questions about just anything Allscripts related, for that matter, group related or Allscripts related.
Hi, Trisha. This is Tammy. I do have a question regarding the new measure for the safe attestation. Is that in addition to the risk assessment that we're already doing?
It is in addition to it. And again, it's yes, we have implemented the safer high priority guide, or no, we have not implemented it. And regardless of which way you answer, it's more like they're trying to gather information, but really trying to encourage practices to go a little bit deeper to make sure that they're protected from a security perspective. There's been a lot of additional ransomware attacks on doctors' offices, and that can be a very debilitating and scary thing. There was one actually that happened very recently, which impacted a large number of professional EHR clients. And so you just can't be careful enough in making sure that you get everyone up to speed on security and how important it is to protect information, make sure that your backups are running, make sure that someone restores that backup every so often to make sure that it really works. There's nothing worse than your system going down and, or your server crashing and you going to that backup that you've been running every night for the last 2 years just to find out that the tape is corrupt or your restore point is corrupt and there's nothing you can do. So it's really important to address those kinds of things, even if, you start small, right?
Yeah, thank you.
You bet.
So any other questions?
Jay, this is Rachel. I don't have a specific question for Trisha, although I'm so thankful that I have Karen Crouch here at my office and Mary Beth Culbertson who deal with MIPS day in and day out, because it's a lot of it I feel like is over my head. So thank you for that very concise explanation. But I did have an idea for potentially a topic in an upcoming meeting, only because it seems like I'm getting asked about this by either Allscripts or Frisia that we also use on a regular basis now. And that's regarding a lot of the innovation being done in the realm of scheduling. So it's not specifically the EMR, but more the practice management side of Allscripts. And there's a lot of new options out there surrounding the scheduling module and analytics being used, and just ways that patients can self-schedule, or referring physicians can self-schedule, or analytics can be done so that patients, the system can reach out to patients and get them into openings, and that only target specific types of patients that meet certain parameters. And we're not doing anything with that. And I feel like scheduling has not had a lot of innovation in the last, since EMRs have really come around. And it seems like we're entering a phase where there are a lot of opportunities to become more efficient in our offices. And so it's just something that I've kind of put on our plate for the near distant future to look into and dive into. And I'm sure there are probably other groups that maybe are already using things and components and having success, or maybe not success in their offices, or they may be interested in looking into it, just like we are.
Thank you, Rachel. That's great. I made some notes here, and that certainly sounds like something we can look for some expertise from Allscripts or other places on. Definitely.
Great, thanks.
Yeah. Any other thoughts or ideas, questions?
Jay?
Yes.
This is Mary Beth. I'm just going to piggyback off of Rachel because Trish and one of her employees, Jennifer Perez, Karen and I do some of the work on the back, but we could not do them without the two of them. I mean, Jennifer, we meet with Jennifer on a monthly basis, and she has helped create a bunch of reports for us, and also has helped Allscripts create some reports for us so that we can run these reports. I just ran some today looking to see where we are in certain categories with the MIPS, because of course the year's coming to the end, to see where we are. And we couldn't have done it without Trish and Jennifer too. So I don't know if everybody that's on this call knows what they have to offer, but they're worth their weight in gold. They really are. So that's all I wanted to say.
Well, great. That's awesome.
I appreciate that.
Yeah, that's I think one of the reasons Trisha's name came to mind very early on when we started thinking about this. We knew she would have some valuable feedback for you guys and some valuable presentation. So thank you again, Trisha.
You bet.
Any thoughts on additional topics for the future, or anything else we can be starting to work on for you guys? Well, like I said before, we're going to send a survey out to everybody to try and get some more information back from you guys. But thank you for your thoughts. Thank you for your questions here. We're going to take just a couple more minutes and talk about one other group feature that we think is going to be important. You know, we know that the networking and the ability for you guys to communicate with each other quickly is important. So I'm going to let Megan talk a little bit about one of the next steps, which is around a forum that we put together for you guys. Yeah. Okay.
Perfect. As Jay explained, we understand that a big part of this group is going to be connecting users and making sure that outside of just our annual or biannual meetings or recurring webinars, that you have a method of communications to sort of talk to other Allscripts users. So in order to do that, we sort of built a forum that you can use. It is at the official Allscripts Mid-Atlantic Regional Users Group website, amarug.com. If you become a member, you can actually click this forum button, in which we have a couple different discussions that we can start or add to. If you become a member and subscribe to the forum, you will get either a daily or a weekly digest of any posts and replies to posts that have been posted in the past day or week, with a link to log in and add your thoughts. This is here so that you can sort of reach out to other regional Allscripts users, get answers to questions, ask questions, and you know, just provide feedback and generate a community that can be helpful throughout your time.
Thanks, Megan. Appreciate that. So, you know, I think, you know, we just wanted to cover that because we feel like that's going to be an important way for you guys to communicate and launch questions back and forth to each other. So, you know, I just want to say thank you to everybody for participating, and you know, we're open to any feedback that you might have to make this group everything you want it to be. But thank you guys all for being here for the first for kicking this off, and still have a few minutes for any other questions or any thoughts you might have.